Hi, everyone, and welcome to today's webinar, Tissue Adhesive, the Future of Infection Prevention for Vascular Access, brought to us by Adhesion Biomedical, the makers of Secure Port IV. I'm Judy Thompson, the Director of Education at the Association for Vascular Access, and joined by Blake Hotchkiss in our Education Department. So now it's my pleasure to introduce our speaker today. Lori Kazmarek joins us today from Milwaukee, Wisconsin. She's been a registered nurse for about 3 decades, and she has experience in the cardiac ICU, cardiac surgery, heart transplants, and she has specialized in vascular access since 2010. She's been in leadership roles in our specialty for the last 10 years. She is currently a vascular access consultant, speaker, and educator. She has been honored with the Excellence in Critical Care Practice awarded, an award presented by 3M Healthcare and the Association of Critical Care Nurses. She's also the recipient of the Coronary ICU Nurse of the Year presented by Aurora St. Luke's Medical Center in Milwaukee. Lori has recently earned her master's degree in nursing and health informatics. She's board certified in vascular access. She's presented locally and nationally on vascular access team management and outcomes. She has a special interest in developing tools for data management, quality tracking in vascular access. Without further ado, take it away, Lori.
Thanks, Judy, and thanks everyone for joining us today. I'll begin talking about my disclosures, which are listed here. You can see that I wear several hats, both as a speaker and a consultant. I'm also a volunteer on the AVA Board of Directors and have been for several years. I was scheduled to deliver this presentation in person to several networks this summer and over the spring, but due to the COVID outbreak, that obviously changed. I do appreciate having this opportunity to present the same information to you now in the form of a webinar, and this will be added to the AVA Academy's growing list of education for review later. This presentation does not reflect the position of AVA unless specifically cited. Today I'll discuss complications of vascular access devices and consider the COVID crisis and how it's impacting care. We'll look at what tissue adhesive is and how it benefits vascular access. And finally, I'm going to share some of the clinical outcomes in some recent studies that describe how adding tissue adhesive can reduce complications and device failure.
Blake, let's kick off poll number 1.
Awesome. This is Blake. Let's start with the first polling question. What is your primary work setting? And that could be primary nurse at the bedside care, vascular access specialist, an infection prevention specialist, infusion specialty, or some form of advanced practice. And it looks like 74% of folks joining us today are in the vascular access specialty.
Thanks, Blake. Back to you, Lori.
I have several abbreviations listed here on the slides. Many of them are well known to most of you. I will use the term tissue adhesive sort of interchangeably with cyanoacrylate because, as you can imagine, cyanoacrylate is a bit challenging to pronounce. So certainly we are living in a stark new reality, and COVID has brought many challenges. These are just a few examples specifically to vascular access, and I'm sure there are many more. Clinicians are reusing masks and their PPE. The PPE is in short supply. And certainly while not the standard of practice, IV pumps and ventilators are being placed outside the rooms to limit clinician exposure and to conserve on the PPE. Consideration is being given to split or share ventilators among more than one patient, and clinicians are fatigued, stressed, and burnt out. I'm pleased that AVA and our industry partners have stepped up to provide suggestions, solutions, and support that may reduce risk to our patients and protect the vascular access device. I'm seeing a great exchange of ideas on social media and through our industry partners on their websites as we try to navigate all these uncharted waters. Things like protecting extending IV tubing and decreasing the risk of infection, or even just clinician injury due to tripping or stepping on tubing. How do we protect the lines from inadvertent dislodgement or failure? How does extending the tubing length impact drug delivery and flushes? Can we reduce unplanned dressing changes? Certainly, a multidisciplined targeted approach is always required to keep patients and providers safe, but this new reality certainly heightens that goal. Looking back at tissue adhesive, it's good to just get a perspective of where it started and how far we've come with it. When you look back at cyanoacrylate, it's really been in the use since the 1940s. First, it was available commercially, and then it expanded to human use in the 1960s and 1970s. Many of us will recall super glue and crazy glue and how that emerged for sale and to consumers. And of course, many of you, and I'm dating myself here, may recall the TV commercial where the guy glued his hard hat to a beam and suspended himself from it using crazy glue. That was an early form of cyanoacrylate. The tissue adhesive has gone through many improvements and form modifications since then to achieve characteristics that are important to clinicians and for specific purposes like protecting vascular access devices. The use of tissue adhesive as a barrier against common microbes has been known and approved by the FDA since 2001. What you may not know is that cyanoacrylate formulas have extensively been used in the veterinary care world and even internally in humans for things like embolizing cerebral AV malformations, pseudoaneurysms, to treat upper GI bleeding, and vascular tumors, for example. Some early studies that used tissue adhesive with vascular access did not use a highly purified formula that's in use today. However, all these studies added to the growing body of knowledge which showed the benefits of tissue adhesive with vascular access and demonstrated the characteristics that are important for our devices. The current formula is known as a 2-octyl cyanoacrylate, and it received FDA approval for use with vascular access to seal the insertion site and secure dressings and provide a microbial barrier.
We'll break here for our next poll and just give me a bit of information about your experience with tissue adhesive and vascular access.
All right, going to go ahead and launch this next poll. So, do you have experience using tissue adhesive in your practice? Looks like we had a lot of participation on this question.
Great.
All right, I'm going to close that poll. Looks like we got about 60%. And we got 40% said yes, you guys are using tissue adhesive in your practice. 53% said no, and then another 6%, but others in my facility do, so maybe not personal experience with the product. So right down the middle, I'd say.
That's great to hear.
Now, I don't know about all of you, but it's been quite a while since I learned about log reduction in nursing school. So a quick refresh here can help explain the action and the impact of tissue adhesive on microbes. The log reduction, or that term, is short for algorithm, and it's used in microbiology to test and compare how different disinfectants or cleaning agents impact microbes. This is a standardized test in the lab, and the products are tested against a 1 million microbes that are on an agar plate to determine their efficacy. Many of the CHG prep or the maintenance products that we are familiar with today carry, for example, a 4 to 5 log reduction, which means that between 10 to 100 microbes may survive the standard prep that we do. And the time to achieve that level of microbe reduction may take 30 minutes or longer. This is great, but if you're the one patient who has one of those surviving microbes migrate into the vascular system, it's not a good outcome. By comparison, most hand sanitizers are listed at about a 6 log reduction, which takes that 1 million colony living on that agar plate down to 1 living microbe. But as, again, we are all aware, it needs to be used according to the instructions. Generally, 6 is the highest log reduction that's reported or seen in the scientific papers. Now, looking at tissue adhesive, it has what's called an anhydrous property. So its mechanism of action is against any of the microbes that are on the skin is to dehydrate them. This comes with a greater than or equal to 8 log reduction against broad spectrum of organisms and is achieved within 3 minutes. It then also acts to seal the insertion site, and then it immobilizes microorganisms and inhibits their migration toward that extraluminal space. Consider the added protection that this can give to your current vascular access care and maintenance. It's important to read the instructions for use, or the IFU, for every product, and the IFU will contain product-specific information about the log reduction. Bottom line, tissue adhesive provides a broad spectrum microbial barrier and a physical barrier once it's cured. There are many origins of vascular device failure, be it peripheral or central. Many causes of failure can be attributed to multiple sources. By this, I mean that a device may fail, or failure may come from infiltration alone, or may have multiple origins. For example, skin damage and thrombosis. Some causes of device failure are obvious to the trained eye, like a dislodgement, while others, like vessel trauma or thrombosis, may go unrecognized until more problems develop. We are challenged as clinicians to prevent device failure, and it's a complex problem to solve. In addition, we must show evidence and cost analysis for every product trial and investment. This is often a daunting task for many clinicians, but it's most successful, in my opinion, when we have multiple disciplines coming together to problem-solve solutions. So there are many origins of vascular device failure, whether it's peripheral or central. Many causes of the device failure can be attributed to multiple sources, and by that I mean the device failure may come from, say, infiltration alone, or it may come from something like skin damage or thrombosis. So multiple factors. Some causes of device failure are obvious to the trained eye, like dislodgement. You walk in and you see that line partially removed or fully removed, while others, like maybe a vessel trauma or thrombosis, may go unrecognized for a period of time until the patient presents or develops additional problems. We're challenged as clinicians to prevent device failure, and it's a complex problem to solve. In addition, we must show evidence and cost analysis for every product trial and investment. This is often a daunting task for many clinicians, but it's most successful, in my opinion, when we have multiple disciplines coming together to solve and put solutions forward. So speaking of value analysis, let's look at the financial impact of device failure. Until maybe the last couple of years, it was always really challenging and difficult to find some of the analysis of those the device failure, the impact. And Lee Steer presented some of this data last week in his webinar and in JAVA, the Journal of Association for Vascular Access last year, about the high failure rate and the complications and the costs that are associated with peripheral IV device failures. I actually, when I read this, thought maybe that average peripheral per patient admission of 10 was on the lower side. In my vascular access practice, it was not unusual to see attempts as high as maybe 14 before an expert was called in. So hopefully in the years to come, we will see that number decrease, that average number, by the interventions that we're employing today. Dr. Helm and Associates, they certainly called our attention to the problem of peripheral IV device failure back in 2015 in their publication titled Accepted but Unacceptable. I practiced as a nurse clinician, like Judy mentioned, in cardiac surgery and cardiology during the 1990s. And like Dr. Helm, who is a thoracic surgeon, pointed out, there's this level of acceptance, or, that peripheral IV complications were acceptable. And I remember in my cardiovascular practice, it was not unusual, or for that matter, unacceptable to us, that a patient would pull through a major cardiovascular surgery or, a thoracic artery repair, only to have their discharge delayed due to having a peripheral IV infection or developing a fever. And when I would often, I'd go back and report that to the surgeon that I had to hold a discharge for a patient due to this complication, while it was met with frustration, it wasn't met with surprise. It's certainly a reminder to me about how we all consider this just part of the landscape in terms of peripheral device failures. And looking back, there was never a discussion, I recall, in my practice about preventing the problem at the time. In fact, Many of our patients had a central line in place for their operation, so sometimes the solution to avoiding the peripheral IV infection was simply to leave the CVC in place until it was about time for the patient to discharge home. And unfortunately, or fortunately, I should say, we've come a long way in understanding what risk that carries, but I think many of us still struggle, and I hear that from clinicians that it's a struggle to change the mindset among care providers. And from 2015, when Dr. Helm reported up to a 63% peripheral IV failure, to then 4 years later in 2019, we still did not resolve or make a significant dent or difference in managing peripheral IV device failure. We certainly had a greater awareness, but in his follow-up article, he poignantly remarked that we are essentially doing the same thing, expecting a different outcome. And he really challenged us to integrate care that would better stabilize the peripheral IV. He commented that the simple transparent dressing and supportive tape was simply not adequate. And as a vascular access specialist and director of our team, I came to appreciate the need to really partner with our value analysis team, our infection preventionists and treatment providers. Too often product changes or substitutions were being made without any decision by key stakeholders. So it was usually one or two people, and that was frustrating. And when Judy mentioned collecting data, that was one thing we did regularly. Was our practice was both in an acute care setting, but also did some mobile vascular access. So we were not invited to the table as often when product changes were made. And in one instance, our data collection started showing an uptick, a sudden uptick in peripheral IV replacements. And we could track that information and saw that when we traced back to what was going on, the hospital had made changes on product without informing key stakeholders, and it had changed and altered the way that peripheral IVs were stabilized and therefore causing dislodgement. Dr. Helm challenges us that peripheral IV care must include things that are clinically simple, highly reproducible, and cost-effective, and we need those interventions to stabilize our peripheral IVs better. And then shifting and looking at our CVCs and the whole scope of CLABSIs, overall we've seen about a 9% decrease in CLABSIs from 2017 to 2018 in the data I was recently been able to pull. If you look back to 2011, when we really started tracking and reporting, at that time in 2011 we had about 70,000 CLABSIs, and we were down to just under 24,000 in 2018. There's about an 11% decrease in ICUs, but general hospital wards still account for the greatest number of overall CLABSIs. And out of that 24,000 in 2018, 18,000 of them were still reported in general hospital wards or units, not in the ICU. We're certainly making progress. I think many of us still continue to debate the numbers that we see. Is it reflective of us improving our care or greater awareness? Maybe it's due to better products or multifactorial in that regard. It could be due to other measures like daily necessity checks, early removal when the CVC was no longer clinically indicated, or does it reflect providers simply inserting alternate devices to avoid CLABSI? We've had many debates and discussions about this in the vascular access world. This is multifactorial for sure, but regardless, the central line failures are equally complex as peripheral IV failure, and they come with a high cost, not just in form, of patient pain, suffering, disability, and death. It's important to know what your hospital's CLABSI rate is, so you can really target interventions that are necessary to improve that outcome and continue to lower that number. So we'll stop here and do two polls back to back. The first is about some of the interventions you might use for your central lines for infection prevention, and then also your peripheral IV care and management. So Blake, I'll let you take that.
Awesome, thank you, Lori. Let's launch poll number 1. This is about central lines. So it's a multiple choice, so you can check whatever you're using. Give it a couple more seconds. And the results are in. Let's see here. So standard transparent dressing alone took the lead, 82% of folks. In addition to that, you'll see 30% of folks are using some form of engineered stabilization device. And then there's a handful of folks that are using CHG gel, the impregnated transparent dressing types, or 7% tissue adhesive. And it looks like maybe 6% fell into that other category.
Great. Thank you all for sharing that. It's interesting when I go back to that discussion about the change in our peripheral IVs in our practice where we noticed that sudden uptick. It was a change in, at that time, went from a stabilization device to then just a simple transparent dressing. So just that heightened my awareness, and even, you know, then, even I think that was about the time when Dr. Helm was writing his article, but just seeing the impact of not having stabilization on peripherals is huge. And that was, you know, like I said, seen clearly in our data collection as well. So I'm going to shift gears and talk about what is tissue adhesive's impact on this problem of device failure. The evidence is mounting, we're seeing more studies, and so I'd like to kind of walk through some of the things that have been published and researched and shared. Let's look first at a small pilot study that was led by Nicole Marsh and her colleagues in Australia, and this was published in 2015. And here they did a single site tertiary hospital. They did this study looking at 4 different securement methods for peripheral IV catheters. And what they did is compared the standard, what we know as a polyurethane dressing, and that was their control, against different types of products with tissue adhesive addition just to that standard dressing. So standard dressing with the tissue adhesive reduced that failure rate compared to all the others. They concluded that the tissue adhesive appeared to be an innovative solution to this problem, but at that time made the comment that it may not be suitable for all patients. And it's important to keep in mind when we went back to talking about some of the different formulations that in 2015, this was what's called an N-butyl formula that was used in the study and didn't have the same flexibility or characteristics in the formula we see today, but it certainly added to our understanding of what kind of characteristics are important for vascular access. And then we look at Bugden and colleagues, and they reported in a study in 2016, and that looked at peripheral IV failure rates in adult emergency room patients, and then they reassessed or tracked those lines at 48 hours. And simply, again, the simple addition of tissue adhesive to the standard of care improved outcomes in all areas. A new study replicating this work is in progress right now. It is tracking the peripheral IV outcomes. Instead of 48 hours, it's going out to 7 days in adult patients for IVs that are started in the ER without ultrasound. We're anxious to see some of that data, see all that data, but the patients in this study are being randomized to receive either standard of care or the standard of care plus the tissue adhesive. So this forthcoming data is really expected to add a lot to our body of knowledge about clinically indicated peripheral IV replacement and if tissue adhesive can extend the dwell time, secure and protect the line. So look forward to seeing that. In this study in 2017 by Dahl and colleagues, a proof of concept was carried out on tissue adhesive, and this was applied to 19 patients that had multi-lumen antimicrobial catheters or CVCs to evaluate the duration of time that tissue adhesive maintained a mechanical barrier and prevented any extraluminal CVC colonization. The seal was maintained between 1 and 25 days, with the mean being at about 6.9 days. 4 cultures were done, 1 that demonstrated colonization. The authors here determined that further investigation is necessary. Obviously, this is a small study, but to determine if that the skin adhesive could lead to reduction in the rate of catheter colonization and collapsing. And Pittarudi and colleagues in 2016 presented a poster at the AVA scientific meeting sharing their experience with tissue adhesive on a variety of CVC devices that led to 100% control of oozing from the exit site. And again, the mechanism here is the site was sealed, and that prevented oozing and minimized the dressing disruptions or the rate of having to, or early dressing disruptions. They tracked and reported on just over 1,400 line insertions. This reduced the unscheduled dressing change, sealed the site. It computes to a significant cost savings if you consider the use of the supplies and the clinician time, not to mention the added risk to the patient due to the early dressing disruption, which we know from studies by Timsent. He concluded that tissue adhesive was inexpensive, safe, and highly cost-effective. And this, I think, really brings to mind the whole, going back to our crisis with COVID right now and the challenges that clinicians are dealing with, trying to reduce the clinician exposure and anything that can be done to reduce the risk of having to replace the line or certainly reduce early disruption, dressing disruption is welcome. In a pilot study at Mayo Clinic in Arizona, this was just published in early 2020, a single site study was carried out, and they were evaluating the effectiveness of tissue adhesive on PICC line migration. And I think we can all attest to dressing changes and having the lines retract. My experience was all in adult patients. So for me, when a line came out maybe a centimeter, we were pretty comfortable with that we were likely still in good position. For other patients, it's much more critical, and especially for a pediatric patient. So it's noteworthy that this particular study was on adult patients. So they did a pilot first looking at 31 patients who met inclusion criteria being in the hospital greater than 24 hours. They were excluded from the study if they had a sensitivity or an allergy to tissue adhesive, if they had an active bloodstream infection, or their skin was non-intact or diseased. And what these authors did here was look at the external visible length, or EVL, that may be an abbreviation not as familiar to most of us, and looking at that PICC, and they measured daily to make sure that the line was not migrating or backing out. And those findings were compared to a similar population using their standard protocol, which used a standard adhesive securement. And in this Mayo Clinic pilot, the baseline data using the standard dressing, the engineered stabilization device, and the CHG disc were compared to the post-intervention group using tissue adhesive and standard transparent dressings alone. What they found was that there were no migrations in the post-intervention group and compared to 6 in the baseline. So they determined to go ahead and proceed with this study. Now, 1 year and over 400 PICC insertions later, the outcomes led to a policy change at their hospital, which eliminated the use of their engineered stabilization device and the CHG disc, and they continued with the tissue adhesive and securement dressing only. They concluded a significant cost benefit using the tissue adhesive and transparent dressing only regimen, and over the post-intervention protocol, of course, and they met their goal of significantly reducing the PICC line migration rate. And though the collapse was not an endpoint of this study, they did go back and look at the differences between the pre and post-intervention groups. So the incidental, what I think is quite exciting outcome, showed no collapses during the study period in the intervention group, whereas a range of between 0 to 5 CLABSIs were recorded during each quarter measured for those receiving the standard of care. And more about the tissue adhesive was shared at the AVA 2019 scientific meeting, our annual meeting, where clinicians from about, I think it was a total of 10 hospitals, they shared information relating to their use of tissue adhesive and the positive outcomes. And 3 of them specifically discussed reduced infection rates. Additional studies, like I said, are in progress, and those collecting and sharing their data will continue to add to the growing body of evidence that tissue adhesive to all vascular access device insertions and maintenance bundles can do to reduce complications and device failures. I'd like to just highlight a couple of them here. The first is called the Peripheral Related IV Catheter Efficiency, or PRICE is the acronym. That's an evaluation that was done at Texas Health in Fort Worth. They demonstrated a reduced peripheral IV dressing disruption from 70%, 70, down to 18% when the tissue adhesive was added to their dressing protocol. And they had an 87% completion of therapy rate. They did a cost analysis that the use of the tissue adhesive would save the hospital about $407,000 in total cost. Of that, $204,000 are direct material supply costs. UCSF Bennethoff, they shared outcomes at their level 1 neonatal intensive care unit, placing ultrasound-guided 1.4 and 1.9 French Piccs using a peel-away introducer technique, and their use of catheter adhesive is discussed as a key component of Picc insertion and their maintenance bundle. No line infections occurred, and 86% of their lines lasted the intended duration of therapy. Dayton Children's Hospital conducted a trial in 2018 on NICU patients and pediatric patients, where their trial was targeting reduced Picc catheter migration, reduced Picc insertion site bleeding and oozing, and sealing the insertion site to reduce the risk for infection. Their trial was successful, and the tissue adhesive was implemented for house-wide Piccs in March of 2019. They reported that since that time of adoption, there have been 0 CLABSIs, which is significantly less than the reported occurrence rates of about 1 per month. And Cincinnati Children's presented their clinical experience with tissue adhesive used at the insertion site and shared their experiences and the interim results of an ongoing randomized controlled trial. The data they presented supports prior studies that have shown improved dwell times and a reduction in the type of peripheral IV catheter failures that's impacted by the use of tissue adhesive. Loma Linda University in California, they became the first hospital to adopt in the U.S. to adopt catheter securement, or tissue adhesive, for securement in all their lines, and that started in about mid-2018, and they now include this technology as part of their bundle and within their dressing change kits, etc. And in a journey to adoption, this was a presentation that shared a case study about a patient with Stevens-Johnson syndrome, and they used tissue adhesive successfully to maintain a line. They also, another presenter in that session, Rebecca Stevens from Glen Falls Hospital in New York, she shared with how their team used the Iowa model to demonstrate an 83% reduction in unscheduled dressing changes. They decreased post-insertion bleeding from 40% down to 4%, and their dressing non-adherence was reduced from 42% to 8% since implementation of this tissue adhesive. She also reported CLABSI occurrence was reduced to 0 in the first 8 months of their use. And finally, a poster by Rady Children's in San Diego shared their experience adding tissue adhesive to their pediatric insertions and their Picc care. They concluded that the tissue adhesive performed well, it was easy to use and well tolerated by patients. The use of the medical adhesive as a catheter site sealant and securement was very promising, and they felt there was a reduced supply, and it reduced the need for additional supplies and staffing costs, such that 89%, they had an 89% reduction in some of their unplanned dressing changes. And in addition, things that we don't, really address often enough is the increase in patient satisfaction that comes with this. In the case of the pediatrics, definitely parents, we have the increased anxiety and stress on them, watching their children have to go through unplanned dressing changes. They had also noted the reduced bleeding, and the dressings remained intact for the 7 days. They further concluded that the oozing and bleeding that they saw reduced the number of the incidents of dislodgement, and they saw a 75% decrease in that. And as I mentioned, obviously dressing changes in general can expose patients to the risk of that line being retracted or malpositioned. It's even in my adult world of vascular access, like I said, we were tolerant of maybe 1 or 2 centimeters of Picc being retracted, but certainly not something that can be tolerated in the pediatric population, where even a half a centimeter can retract a line and pull it out of position. So anything we can do to maintain that line and secure it, stabilize it, is a plus. So in summary, I just want to close this presentation. I just want to recap some of the highlights and some of the benefits that are being seen with tissue adhesive and seen in the studies and the reports, and certainly something that you can add to your vascular access toolbox. Like I said, it's very effective against gram-negative, positive, gram-positive yeast and fungi that are commonly associated with our device infections. It immobilizes microbes that may survive that standard prep, and it seals the insertion site to stop oozing and protects against extraluminal contamination. It's quick and easy to implement, can be added to your existing regimen. It's safe to use on all ages, from our micropremies to our centenarians, and has no adverse effects reported to the FDA in terms of the tissue adhesive for vascular access. And lastly, tissue adhesive benefits all vascular access devices, so you can customize how you want to use it within your organization based on the outcomes and goals that you have. And that's something that I speak a lot when I'm meeting with vascular access networks and teams, talking about the importance of your data collection and knowing what your outcomes are, so that you know the impact of any product that you might use for your patients. As we consider the rapidly changing landscape that COVID is bringing, I just want to say thank you to all those on the front line, and a shout out to all our industry partners, our key organization leaders, for their continued support and expertise. This support, I think, is so vital as we continue to maintain and protect the vital lifelines of our patients, and at the same time reduce patient and clinician risk and reduce the consumption of the vital resources like personal protective equipment and the time needed to restart lines. So I'm going to turn this over to Judy and Blake. It looks like we should have some time to entertain questions along here. And again, I apologize for the difficulty we have with the audio, and hopefully we can answer any questions if they came up during the presentation.
Gloria, that was great. Thank you so much for the information, and sorry about the technical issues. So we do have quite a few questions. I think Blake is going to take the lead here and ask you a whole bunch of this.
Thank you. Yeah. So you kind of touched on this on the last section of slides here, has it been verified for the use in neonates?
It has.
Yes.
The approval, yes, it has been approved, and for any age. So there's no age restriction on the use of tissue adhesive for vascular access.
Perfect.
And it is approved for all vascular access devices.
Have you heard of a lot of different teams using that in the neonatal populations, or?
We have, and interestingly, I always share the story with some of my colleagues that the first time that I was out doing some education, it was actually in our neonatal and pediatric population. And I think some of the early adoption in that patient population tends to come with, there are limits sometimes to what product or products they can use. I know, and again, my experience was all adults, so I had a quick learning curve, but some of the neonate and pediatric, they don't use a lot of chlorhexidine products depending on age. So they really were struggling with lines, malpositioning or retracting, securing. They have a very tiny landscape or area to secure dressings to. So it's always a challenge. And, as much as we might struggle on an adult with product, it's really amplified when you have just a tiny person and really a limited area or target to use it on. So actually the early adoption, I think we can safely say, was with pediatric and neonates for sure.
Awesome. Here's another question. So I've considered using glues before. I'm curious how you prevent the glue from causing an occlusion inside the vessel if it creeps inside the vein. How is it just kept as at the skin barrier?
And that's a great question, and I've heard this before. First of all, you're not putting on enough that it's going to track all the way into the vasculature. And the important piece to remember is the anhydrous property of cyanoacrylate or tissue adhesive is it's curing on contact so it's using the water molecules that it's finding. And so if there's moisture in the, like I said, the cells, but also around the insertion site, it's sealing and curing there. There's been no evidence or like I said, you're not using enough volume that would be able to track that distance into the intravascular space.
Okay. All right, let's see, another question here. At my facility, they just started using securement device, the glue, for Picc lines only. Is it routinely used for peripheral IVs?
It is, and again, its use is expanding. Different hospitals will start off basically targeting a specific goal, and that's where your data collection is important. I think the not the frustration, but what becomes clear is that we all in general in vascular access have not studied our peripheral IV outcomes as well as we have our central line outcomes. So we don't really know how much of an impact we can change. But I think what I can comment on is what happens is that the initial target or the goals are to address an outcome specific to a central line or Picc lines. And once those outcomes are achieved, there's usually an expansion of the product to, say, peripheral IVs or other devices within the facility. So it continues to be a progressive opportunity to improve care among the many devices that we place.
And I think it's interesting if we go back to the polling questions, when you look at CVC care maintenance versus peripheral IV care maintenance, the disparity between the results that we saw, almost like any vascular access device should be treated in a similar fashion. And something like tissue adhesive is a great adjunct to kind of bridge the gap between both those ends of the spectrum.
Exactly. And that's where I think that we're seeing that movement, and you hear that in the vascular access community. There's more attention, not just from Dr. Helm and the articles that are out, but we're really looking at the numbers critically of peripheral IV device failure and the cost to the patient, to the hospital. And I think as that continues to become, an emphasis, we're going to be increasing our looking for product or to our industry partners, what we can do to secure and stabilize those lines. Like Dr. Helms article wrote when he added that in 2019, we really need to look at something that's stabilizing the peripheral IV, and that's where the majority, at least what he reported, our majority of our failures are coming in. And so some of the studies that are going on now, like I said, the one study that's replicating and looking at peripheral IV catheters placed in the ER out to 7 days, it's going to be very exciting to see, not just in the realm of how does tissue adhesive impact that, but how maybe it's location, because that study, as I understand, is really not restricting where the IV is placed. So if it's antecubital, if it's at the back of the hand or where, but it's looking at all these variables. So it's going to give us a lot of important information about peripheral IV care and maintenance, in addition to something that could be simple and effective in terms of stabilization for the peripheral lines.
So here's another question. Do you recommend using tissue adhesive instead of or in addition to the CHG disc or dressings on central lines?
That really comes, and that's a great question. And like I said in the presentation, you can add tissue adhesive to your existing toolbox. And I think that's where many people start. It's important, though, to know what your data and your numbers are showing now so that you know what you want to impact and change. So I would tell somebody, honestly, if that's working and they have a acceptable or a 0% infection rate, you're obviously not looking at it as something you need to change. But I don't think most of us can say that, honestly. We're looking at how can we use multiple products or use the things that are available to us to impact and make that change. So you might want to start by adding that to your toolbox, and then if you look at the study that was done at Mayo in Arizona, they did two distinct groups, one that did have that disc and one that didn't. And that was really impactful to see, to go back and just see the incident. It wasn't that, like I said, their intended target, but to see that they reduced that level to 0 in that group. We still need continuing data collection and reporting to validate that, but that was very impactful to me. So I guess it really boils down to what your numbers are, what you want to change. Start off so that you have a baseline data, and then implement. Certainly, like I said, you can add it to your existing regimen and make changes based on your outcomes and the numbers that you see.
Here's another follow-up, I guess, with the tissue adhesive. Is any significant skin sensitivities or allergies reported with this or the use of the product?
We have not seen that. And like I said, there was, there's a website that you can go to it's on the FDA.gov, which is probably inundated right now with other people looking at COVID things. But there are no adverse reports or events that have been submitted. Personally, my experience is that we've not seen any like Marcy skin injury or rash or allergic reaction. And interestingly, you'll have patients that are sensitive to just about any kind of adhesive, transparent dressings. They're really limited to maybe just simple tape and gauze, and even that is a challenge for them, that have successfully used tissue adhesive for securement and for protection. So we need more case reports like that so people can share their experiences, but again, have not seen any skin reactions, rashes, or issues of skin tears from it.
Along a similar line, where we're stopping oozing at the site with the tissue adhesive, the question here is, has there been any increase in hematomas or any kind of subcutaneous bleeding related to kind of like plugging the hole, so to speak, with the tissue adhesive?
No, and the answer to that is, I think what's important to understand is the sealing of the site. You need to not have what I would call an active bleeder or a pumper. If you're So if you have to do a skin nick with your scalpel, or there's active bleeding, or there's coag issues, you really need to get control of the bleeding like you would any hemostatic agent that you would use to control bleeding. You can't just have it kind of a river of blood backing out to get the control. The control that you'll find with tissue adhesive is that what I would call oozing that is enough to soil a dressing or to soil your CHG. That's what it's going to stop. So it's more on a, what I would call a capillary level. So if you can get control of the bleeding by pressure, which is obviously the first thing that you want to do in any regardless of what you might use to control afterwards, you want to get good control of the bleeding. And usually if you can lift off your gauze and get about a 15-second, 10-second period where there's no active bleeding, you will likely be more successful using tissue adhesive to seal that. When you're talking about hematomas or bruising, if that blood is backing up, it's usually from some other trauma deeper inside to that vein or vessel. And again, the tissue adhesive itself is not enough to tamponade that. You need to obviously do a technique ultrasound guided so you're not damaging the vein or getting back bleeding. And we do, have seen if you have active bleeding, that still requires, coagulation, a different type of anticoagulant to suppress that bleeding. That it's not going to be effective if it's, like I said, almost hemorrhaging or continually bleeding back on you.
Excellent. Let's see here. Another, like a care maintenance question. When you're doing your 7-day dressing change, and it was pointing out the mean fail rate of the tissue adhesive at being 6.9 days. When we're doing that dressing change, are we going to be reapplying the tissue adhesive at that time, or does it just the one and done when you insert the line?
No, and that's a great point. It should be reapplied, and that's what's usually recommended is reapplication with dressing change. So just like a regimen that you would do right now with your dressings, your care and maintenance really doesn't change. You would replace, if you're using a CHG disc or a gel dressing, you would replace and refresh all those. So really, it's an addition to your toolbox, but nothing changes in terms of that care and maintenance. And yes, because it's over a period of, say, 6 to 7 days, what you'll find is that will gently lift as your skin cells are regenerating. All of us, we shed our skin cells and things regenerate underneath there, even with the dressing change on. So you will continue, you will lose some of that effect. So it is recommended to reinforce that at the dressing change.
Okay. Do you need to remove the product, like use like a detach all, or would you just cleanse it with the chlorhexidine sponge?
That's great to point out. Care and maintenance, really you don't need to change or remove any of the existing tissue adhesive at a time of dressing change. In fact, if you go back and think about the action of sealing any microbes and immobilizing bacteria migration, that you don't want to interrupt or break that seal. So you're just reapplying and adding that to your regimen. The time when I've seen clinicians use, for example, adhesive remover might be at the time of the removal of the device, when they want to remove any residue of tissue adhesive that might be left on the skin. You don't need to do that even at that time. You can leave the tissue adhesive on, whatever residue, it will just gently lift off and really cause no complications or have any disruption for that patient.
How about device removal? Have you seen any issues with the device having a hard time coming out related to using this tissue adhesive?
Removing the device now, the product, when you use a tissue adhesive, it tends to do what's called cure rather than, it was a concept hard for me to grasp, but instead of drying by air, which we normally, talk about when we're using, like say, a chlorhexidine prep. This will cure by moisture, so it's a little bit different process. Again, it's seeking out those water molecules. Becomes its strongest or at its highest strength maybe at about 48 hours after application. So if, say, you were removing a line at that point and you noticed a resistance, sometimes just moving the line in, say, a 90-degree angle will be enough to release that tissue adhesive to remove the line. Just like any product that you have or any line that you have in, if there's resistance to removal, that's when you can, just add whatever tissue adhesive or removal that you have already in your hospital. You don't need anything specific. Just lay it over the insertion site, and usually within about 10 or 15 seconds is enough to soften it. But generally at about, say, 7 days, or even after 5 or 6, I've not heard any case reports or clinicians reporting that they had difficult access. The lines that are, your very tiny lines, I'm talking about 1.4 to 1.9 French, those might, if you were removing them. Now, what I understand a lot in that world or domain of pediatric and neonate is that they may not change those dressings or disrupt that line until the line is actually being removed. So they can go sometimes as long as, I've heard, 14 to 21 days before they change that dressing. So certainly by then it's released enough off the skin that they can remove that line safely and without resistance.
Well, that's impressive. Do you need a prescription or a written order from a physician to use this product or a product like it, like tissue adhesive?
No. You will want it obviously built into your policies and procedures for the hospital to however it's going to be used, but there is no specific prescription that's needed for it. It's a technology. If you think about it as a technology, and it's not a, I guess I would call a drug, if that's what the question is asking.
Right. Yeah. It seems more like,
Yeah.
Like you would use a securement device. You wouldn't have necessarily an order
Correct.
for that. It would be part of your bundle.
Correct.
Yeah. How about this? Has there been a correlation in the reduction of CLABSI with the reduction in frequency of dressing changes? And I'll let you take that one.
A reduction in CLABSIs to the reduction in dressing changes? Is that?
Yeah, I think we're still in dressings every week. It would be, I don't know if it would necessarily change our frequency in dressings, but does the tissue adhesive itself allow you to go longer than that? I mean, INS would recommend regular dressing changes at a.
I have not seen any evidence that would put us in that scope beyond the 7 days. I think all the evidence that we have at our disposal right now is looking at a 7-day dressing change. So this technology, certainly in my mind, we don't have enough evidence to say that changes that. I think what's going to be important over the next years and 2 years is how this is being employed in different situations. And by that I'm talking about understanding better, for example, looking at how the longevity of a peripheral IV might be maintained longer. When we look at the Bugden study, it was 48 hours. Now we're looking at, what's the outcome at 7 days. And I'm particularly interested in seeing what that outcome is in terms of infection or phlebitis, or and if that makes a difference in the outcome of those peripheral IVs in that regard, because that can certainly add, it's information we definitely need. We're not protecting our peripheral IVs. I thought it was interesting on that question about peripheral IV and maintenance that some are placing, for example, a transparent dressing with the impregnated CHG onto their peripheral IVs. And I think that we're seeing more and more of that we're understanding that we need to protect those peripheral IVs just like we do our central lines.
No, I would agree with you. I think it's interesting as looking at the infection prevention community and regulatory bodies, and I think one of these questions actually spoke to the, collapses being reported in that process, and then, thinking down the road, at what point does, a catheter-related bloodstream infections, where we start really looking at peripheral IVs and some of the complications associated with the, accepted but
Exactly.
unacceptable,
Yeah. And it's something that I think our attention is definitely gaining traction in terms of more of us are aggressively looking at how can we impact care, not just in terms of the length of time that we can dwell that peripheral IV. And I think I would safely say that a lot of that movement to go to a clinically indicated replacement, started when we started looking at, do we need to, what are we doing differently for our peripheral IVs, and how can we adequately maintain them longer? I guess I use the example in our vascular access world. In my team, we would often be called to replace a functioning IV just because that IV met that either 72 or 96-hour mark. And so it was a lot of time and effort spent on conversations with physicians to allow that maybe peripheral IV to dwell another day. So as we continue to look, though, at infection rates on peripheral IVs, we need to look at what are we doing differently to protect patients, because I think there's a lot of gray area between, just letting that peripheral IV, the same care and maintenance as we're doing now, go to 7 days. What's happening to the patient, what's happening to the line at that point, and can we use technologies that we have available that might decrease the risk of infection, such as a tissue adhesive, and certainly stabilize that line better for that duration.
Yeah, and it's interesting. By the way, folks, you guys are dropping a lot of great questions here. Trying to keep up with them. It looks like, several of the questions were related to, looking at this CLABSI rate reduction, and is that stemming from how well something like a tissue adhesive is at, like, one, securing the device better, and two, eliminating the PRN dressing changes in that first 7 days, or between your 7-day dressing change. Just kind of remarkable how some of these adjuncts are really helping to improve, again, the whole care and maintenance phase of the life of a vascular access device.
Right. And certainly the studies that have really only one variable, and so, mind you, some of the, like I mentioned, the early pilot studies were not enough high of an N number, certainly, but they point at just changing one variable can decrease complications. And so when you see that, and you see that replicated in multiple studies, that's where I think we gain traction with evidence of what's making the difference in that care. Certainly, I think it's important to look at that micropistoning or micromotion of peripheral IVs. All of us that place peripheral IVs, we're looking carefully, especially when we're doing ultrasound guided, at putting them in an area that's avoiding flexion, and we know some of those target spots where we have best outcomes. And so if we look at that and change that one variable, like Dr. Helm's article is talked about, was that you're using that simple transparent dressing and maybe supportive tape, but we're expecting a different result. Well, now if we can add one technology and see what that outcome is, it really supports the need to stabilize, protect, and seal that site so that we're preventing any migration of bacteria causing device failures.
Well, I think before we wrap up, I'm going to shoot two more questions. One was, when we look at any kind of product that we use for vascular access device, after insertion, dressings, etc., we're always looking at pros and cons. Are there any real cons or negatives to using a tissue adhesive when it comes to vascular access devices?
Like I said, I have not seen any negative reports, any issues with skin integrity or rashes, skin tears. I think there's a lot of benefit to, at least in my experience, is that especially for dressing, minimizing dressing disruption, which I know is, always important, but even more mindful now when we're in this COVID crisis, is not having to go in and change dressings that should not need to be. You risk clinicians adding more, maybe tape, or adding more things to try to secure that, or wrapping the device so that you occlude visibility. That adds risk. So all the things that, if we can look at what's going to be the safest thing, that allows direct visualization of the site, so that we can protect the catheter and minimize those disruptions. I think that's going to be very favorable.
Yeah. Had a couple questions. You had mentioned an acronym in your slides for PRICE. What does that stand for again?
That was a study done, let me just get the whole acronym back here in my mind, Peripheral Iv, and it was a reduction, let me just pull up here, make sure I have the whole acronym again. That was the Peripheral Iv protocol that was looking at peripheral related intravenous catheter efficiency. So they were looking at, again, the disruption, and they, in that PRICE study, reduced their peripheral IV dressing disruptions from 70% down to 18% just by adding tissue adhesive alone.
Wow.
So that's also in the reference list. You can find a reference to all the scientific presentations as well that I mentioned here in this talk.
That's awesome. I want to thank everyone for, again, all the great questions. I think just reading through them, kind of try to keep them in a logical line of questioning. So thank you guys. Appreciate that.
Thank you. Lori. Oh, sorry, Blake, I didn't mean to interrupt you.
I was saying, take it away, Judy.
Thank you. Lori, you did a great job. Sorry about the technical difficulties. Adhesion, thank you so much for offering this program. And it will be up on AVA Academy next week. It'll also be on AVA's YouTube channel. And hope to see all of you guys tomorrow at our next webinar at 4 p.m. Eastern. Thanks, everybody. Be safe out there. And thanks for everything you're doing. Bye now. Hey, Blake, my screen's frozen. Will you close this, please?